ودلوقتي معادنا مع الأخت الفاضلة والابنة العزيزة الدكتورة ياسمين جمال. دكتورة ياسمين جمال، دكتورة ياسمين معانا؟ دكتورة ياسمين؟ دكتورة ياسمين؟ أيوة ظهرت أهي. طبعا برحب بيكي يا دكتورة ياسمين. دكتورة ياسمين أستاذ مساعد طب الأطفال وأحد أعمدة وحدة التغذية الإكلينيكية عندنا، ودلوقتي كمان الحقيقة مدير مستشفى الأطفال جامعة عين شمس. عليها لود كبير جدا، ربنا معاها وربنا يعينها وربنا يوفقها، وكلنا وراك يا دكتورة ياسمين وعارفين اللي انت بتعمليه كويس قوي. ربنا يكرمك. وانا مش هطول في المقدمه، كان نفسي اقول كلام حلو قوي بس عارف ان انت اللي مستعجله.
تمام يا بيدا، يعني كفايه عليا، ربنا يخلي حضرتك.
مش قادر اقول كل اللي جوايا يعني، لكن اتفضلي يا دكتوره ياسمين. معاكي. اتفضلي ابتدي البرزنتيشن بتاعتك. انا عارف ان هي وراها ارتباط بعدين على طول، فان شاء الله يعني تخلص في التوقيت المناسب. اتفضلي يا دكتوره ياسمين.
شكرا دكتور إيهاب. I would like to congratulate Professor Hanan and Professor Tariq Abdel-Gawad for the first conference in Egypt. الحقيقة always a pioneer، قدوة لينا. بشكرهم وبشكر فريق البيكيو، الحقيقة فريق أكتر من رائع، أساتذتي زملائي. بشكر دكتور إيهاب ودكتورة مي. It's an honor just to be amongst you ويعني إن شاء الله بكل نجاح والتوفيق. A very highly scientific informative conference. الحقيقة دكتور ميرفت يعني سهلت عليا القصة. She covered all the aspects of enteral nutrition. She covered all the aspects of parenteral nutrition. Just have to highlight some. يعني she made my job easier. I would also like to highlight the importance of nutrition in our center, Ain Shams University. The pioneer also in nutrition support in pediatric patients. We have shared publications with Professor Hanan and Professor Mir, early introduction on enteral nutrition, about the use of diet-based formula, about a lot about the nitrogen balance in our our center is really nice. We started using the indirect calorimetry 10 years ago. We were pioneers in introducing it. I hope that we will have it one day. So this is a slide that explains our condition. Nutritionists, we always have to debate with the surgeons about the nutrition of our patients. Surgeons, they have the nutrition is not in their back mind, and we also have to debate about starting early enteral nutrition, starting parenteral nutrition, supporting the patient, because this will have beneficial outcome for the surgeon as well as the pediatrician. So nasogastric feed, Mr. Jones, no, let's not complicate things. Nutrition is always perceived as a complication. Surgeon gets no respect. Swiss survey of the very operative nutrition, 173 surgical departments, 80% agreed nutrition decreases complication, 59% decrease the hospital stay. So all of us are agreeing that nutrition is important, yet only 20% implemented routine screening and early nutrition intervention in their parent. Where does the nutrition fit in the surgical risk reduction? Appropriate and timely nutrition therapy, the loss of mass during stress, fewer DVT, pulmonary embolism, less pneumonia, out of hospital earlier, less hospital stay. Early enteral nutrition, as elaboratively discussed by Dr. Mirvet, decrease the mortality, decrease infection, complication, and bacterial translocation, maintain the mucosal barrier, maintain the integrity of the GIT, attenuate the metabolic response. Some specific nutrients have beneficial effects, especially in surgical patients, like the fish oil, arginine, and glutamine, and probiotics. They all have sufficient evidence for the use in surgical patients. This is the metabolic stress response already discussed by Dr. Mirvet, which aims to catabolism. It aims to hypoglycemia in the blood. We have glycolysis, we have proteolysis, lipolysis, catabolism. They increase the hypoglycemic effect, and they aim for the tissue repair and wound healing. The metabolic stress in the stress during illness in children is really less pronounced than adults. In cardiac surgery, the metabolic stress is hypomosaic, hyper or hypo, sometimes normal metabolic states post-surgery. This highlights the importance of the indirect calorimetry, which I hope will be in our center soon, because the predictive equations cannot help us post-cardiac surgery. Abdominal surgery, increasing the resting energy and expenditure 4 hours, followed by return to the baseline after 12 to 24 hours. And this is less pronounced than adults. Surgery in general, hyperglycemia response negatively correlated with age. It's 12-hour in neonates and around 2 days in children. So as we know, it is less pronounced. Sustained protein breakdown may result in significant loss of lean body mass during critical illness or post-surgery. Let me discuss with you that only loss of 10% of lean body mass increase morbidity and mortality by about around 20 to 30%. Accurate assessment and delivery of energy to match the patient demand is an important goal. Unintended overfeeding is associated with poor outcomes. We need to have accurate assessment to prevent overfeeding. Overfeeding my patient, if I want to be on the safe side and I'm giving a lot of calories, I will have the hyperglycemic effect, increase ventilatory work. I cannot wean my ventilator, increase CO2 production. I cannot remove my patient from the ventilation, and fatty liver. If the patient is underfed, of course, he's malnourished with poor wound healing, with poor surgical outcome, impaired immunity, and impaired growth. The common predictive equations are not the best thing. The indirect calorimetry is the golden standard of assessing energy in critically ill children, whether they are post-surgical or whether they are critical. Yet we are only now, we only have our predictive equations nowadays, which are the Schofield and the WHO. Both are validated for children. Other equations are not. And it is recommended to use the Schofield equation without routine inclusion of stress factors, because sometimes we multiply the energy, the resting energy expenditures times the stress factor in WHO equation. Regular reassessment is necessary. If I'm using one equation, I should stick to the same equation in assessing my patient, so I shouldn't have a lot of variability in assessing an energy. Nutrition in surgical patients, poor literature in children, evidence only in critically ill children. In spite that in adults, we have a new division of medicine called the ERAS, which are the enhanced recovery after surgery. A lot of publication, a lot of data regarding the ERAS, yet the support of pediatric surgical patients is lacking. Nutrition intervention in the surgical patient has 3 phases, whether it's pre-operative, I'm going to support my patient before the operation, operative during the operation, or post-operative nutrition. I have to have the right patient, the right timing for nutrition, the right formula, the right route of delivery, and calculating the needs exactly as discussed before. Pre-operative nutrition support, if I'm planning for pre-operative nutrition support in patients who are malnourished, patients who are unable to take nutrients or retain the nutrients with malabsorption or short bowel, for example, those who should not take nutrients by GI because of an inherent risk or complicate management of the current surgical disease. Nutrition supports should be administered for a week to 2 weeks to moderately or severely malnourished patients undergoing major GI surgery. We have a lot of abdominal repair sometimes, ileostomy closures, a lot of surgical intervention that need a sound, nourished child with good levels of protein and good anabolism to ensure that this surgery will succeed and the patient will not be faced with burst abdomen, for example. How to conduct the accurate nutritional assessment? Screening is mandatory. Every child that enters a hospital should be screened, and we have a lot of research done in our unit by Professor Ihab Khairi and Professor May Nassar and Professor Sana Youssef. We screened all the children entering in school in our hospital, and malnutrition was detected in around 60% of admitted patients. This is a really high burden. So if we screened first, and I'm sure Professor Ihab will explain this thoroughly, we anticipate, we give early intervention with better outcome. We take a detailed history, whether there's a chronic disease, whether there's a metabolic stress, anthropometry and biochemistry, and medical examination, of course, to have the right plan. Indications of nutrition support: severely malnourished, clinically malnourished children, weight for age, Z-score less than -2, weight for height, Z-score less than -2, stunting and underweight. Serum albumin is really important. If it's less than 3.5, this patient needs support. Recent loss of 10% or greater of the weight, history of recent poor intake, and children that I'm anticipating to be nothing per us for 5 to 7 days. If I'm doing something related to the esophagus, the patient will not be able to have enteral nutrition, then I should support my patient preoperatively, especially the short bowel syndrome. Indication of nutritional support patients who are expected not to feed in 7 days: prolonged ileus, intestinal obstruction, pancreatitis, major bowel surgery, esophageal replacement, gastric or colon surgery. All these are anticipation for MPO for at least 7 days, and I have to support my patient during this stage. Of course, caustic ingestion, esophageal stricture, esophageal replacement, all these are operations that I'm anticipating that there will be no oral intake for this patient, and that this patient should be supported and should have a nutrition plan so that we will not enter in a catabolic state. High-risk procedures of existing data to support pre-op risk reduction plan: colorectal surgeries, upper GI surgeries, abdominal reconstruction 38%, pancreatic or major hepatobiliary surgeries about 22%, major head and neck surgery, major reoperative or trauma orthopedics, bariatric procedures, major cardiothoracic surgeries. All these need the support. The right timing: preoperative nutrition support should be administered for 7 to 14 days to moderately or severely malnourished patient undergoing major GI surgery. Whether it's enteral or whether it's parenteral, they have to be supported. If in operative nutrition, we hold the TPN during operation, if it's more than 1.5 hours, 2 hours pre-operation, decrease the TPN to 50% for 1 hour, hold TPN during the operation, start glucose infusion 10% at the same TPN rate, monitoring, of course, the blood sugar. 6 hours post-operation, I can resume the TPN of the patient at 50% of the rate for 1 hour, then increase the rate till reaching the goal, monitor blood sugar during all these alterations. Post-operative early entry nutrition, as evidence as shown by Dr. Mervat in all the study, all the guidelines, all the critical society guidelines, early entry nutrition is the key. In 24 to 48 hours, the earlier, the better, keeping the integrity of the GIT. TPN, if indicated, using parenteral nutrition in case when the gut does not work, because we have, if the gut works, use it or lose it. If the gut is not working, if there's an ileus, or there's an obstruction or hemodynamic instability, parenteral nutrition is indicated. MPO for 3 days in malnourished children, 5 days in well-nourished children. And we have this algorithm, when to start TPN and when to withhold TPN. In a well-nourished child, as shown by evidence, 5 days, mild or moderate malnutrition, 3 to 5 days, we can withhold the TPN. Severe malnutrition or stress, the maximum time that we can withhold our parenteral nutrition is 3 days. So we shift to the right route of delivery, whether it's enteral, parenteral, or combination of both. We can have enteral, and we are not meeting the needs of the patient enterally, so we complete the calories that are defective parenterally, or which happens in around 90% of our patient. And the decision is about the functioning GIT. If it's functioning, enteral route is the preferred route. Whether it's short-term, in 6 weeks, nasogastric tube, long-term, we can have a gastrostomy for the patient. GIT is not functional, it is the parenteral route. Short-term, we can use the peripheral parenteral nutrition, take care of the osmolarity of the fluids. If you're going to give glucose more than 12.5%, we have to use the central route. If it's long-term, it is central parenteral nutrition. Enteral versus parenteral, which has a superiority in different surgeries: laparotomy, ulcerative colitis, Crohn's disease after resection. Enteral route is better, and this is level 1 evidence. Liver transplantation, enteral nutrition carries an equivalent benefit to parenteral nutrition. Acute pancreatitis, TPN carries equivalent benefit to jejunal feeding, because gastric and duodenal feeding, they increase the complications of acute pancreatitis. So the only allowed route of enteral nutrition is via the jejunostomy. Choosing the right formula, types of enteral formula. We had a study with the ICU group headed by Professor Hanan and Professor Mervat, and it was published internationally, about the use of semi-elemental formula, which is a peptide-based hydrolyzed formula, and it's used in the critically ill patient with a lazy GIT and in the phase of recovery. Yet the guideline states that the best formula for our children critically ill post-surgical are the polymeric intact formula, better high-calorie formula to be given post-operative. If the patient is really critical, semi-elemental or peptide-based formula carries the superiority of better tolerance and decreasing interruption, as was proved with our research. Elemental or amino acid-based formula, they are used in short bowel, ultra short bowel, and short bowel. They are used as a line of therapy post-surgery, and in, of course, alcoholic allergy and multiple allergies. Modulation, we can increase the caloric content of whatever formula we're giving, if it's standard formula, by modular, either giving fat or giving a protein-free, high carbohydrate formula. And we have disease-specific formulas used for metabolic disorders. For example, we have the MCT formula, more than 80% the monogen, which is used in post-surgery if there's complication of chylus thorax or chylus abdomen. So the use of the formula and the right choice of the formula is really important. Other immune nutrients that can enhance the immunity and enhance gastrointestinal surgery, enhance the recovery. 74 studies, 7,000 patients, meta-analysis using multi-treatment analysis. Use of immune-enhancing nutrition outperformed other nutrition regimens in reducing complication, infection, anastomotic leak, sepsis, and mortality. And we had really a good experience with giving our patients post-resection glutamine, which is in the market as dipeptivan, which is an amino acid that improved the healing and decreased the hospital stay of our patient. The dose is around 0.2 to 0.4 gram per kg per day, whether it's IV through dipeptivan or it's oral supplementation. We tried the IV. And a lot of studies about the effect of omega and nucleotides, and of course the vitamins and minerals covered perfectly by Professor May. My take-home message is nutrition in surgical patients is mandatory. It can make a difference. It improves the quality of life of our patients. It improves the surgical outcome. It is important for both the surgeon, the clinical nutritionist, and the intensivist to ensure the safety of our patient and improving the quality of life of our patient. And thank you.
Thank you, Professor Yasmin. An elegant lecture as usual. I am very sorry
Thank you, Professor Hanan.
In the next few minutes because you have obligation. I cannot see specific questions for the post-operative. However, if any further questions, I will send it to you to write it down.
Definitely, definitely. Thank you, Professor Hanan.
We always have you with us in our conference, and it's a great honor to us, Professor Yasmin. And it's
always a pleasure. It's a pleasure to be on your team, dear Professor.
Yes, yes. Your great effort in the health hospital as a director of the pediatric hospital during this era, you are doing a great job. Thank you, Professor Yasmin.
Thank you, Professor Hanan.
And thanks for accepting our invitation.
Thank you, dear Professor.